welcome everybody. This is a great sunny day in Seattle, and wow, I think people would be rather outside. But we have a great lecture tonight. Thank you for coming, and Dr. Broderick is going to speak in a few minutes, but I'm going to present a few topics first related to sleep, and hopefully some fun slides for you. So just the other day, in fact, I happened to find this magazine. I brought it with me, and it was put out by the UW Foster School of Business, and it's one of these probably quarterly publications of who's who and who's doing what, and actually found a really good article on sleep. It was kind of a full page deal, and I'm going to share a few points from that, which I thought were actually pretty interesting. So Christopher Barnes, who's an associate professor at the UW Foster School, I think his career started in the Air Force. He did a lot of studying on fatigue countermeasures. You know, you don't want that plane to be falling asleep and flying to the ocean. And then went through Michigan State, did a lot of learning and research, and ultimately one of his publications was entered and published in the 2009 Journal of Psychology. He was interested in workplace accidents and injuries, interestingly, spiking on the day after we turn our clocks ahead. And technically, and I'm sure Dr. Broderick might comment on this, you know, you're only losing an hour, probably even less than an hour of sleep, but how profound that was to see that kind of data. So he did more research. One study was looking at insufficient sleep and how it compromises self-control. Sleepy workers tend to act less ethically. That's interesting. And then a recent study looking at late night use of smartphones, all of our gadgets, and how that results in a less engaged and effective employee in the office the following day. So this is a quote from that article from him. We are learning that when people are short in sleep, they're less creative, less innovative, less productive, and more likely to make mistakes, behave unethically, and cyberloaf. I think that's a modern word. I don't think cyberloaf existed a few years ago. And so he comments, you know, when people get busy, sleep is the first thing to be sacrificed over work or family time. And I guess, you know, I think that's probably true for me. You know, kind of sleep can go second place when we have things that are important going on. But it really is an easy thing to deprioritize, especially if we just don't know or recognize that even small amounts of lost sleep really do matter. It's not like you're doing, you know, an all-nighter like when you're in college. So, a couple slides for you. So whether you are in an old castle, that's Cragdorrock Castle in Victoria, or in a car, or on a boat, that's the Clipper, or in a fancy hotel room in Vancouver, in a bunk bed, or on the floor of your new bedroom without a bed. Sleep is really important. So I'm going to get set up for Dr. Broderick to educate us and teach us a bit about cognitive behavioral treatments, and hopefully we can get better sleep. So.
So today I wanted to talk to you a little bit about cognitive behavioral therapy for insomnia, which is a very specific type of treatment for a very specific type of insomnia. And you probably already know, but insomnia is a symptom, so it's a very generic term. And when sleep doctors talk about insomnia, generally they're talking about a very specific type of insomnia called psychophysiologic insomnia, or PPI. And I'm going to talk about what the diagnostic criteria are for this type of insomnia, because CBTI, or cognitive behavioral therapy for insomnia, is a treatment for this specific type of insomnia. So one of my jobs is, when I see people who have insomnia, is to determine the cause and the type of insomnia, and this is a very common type. I'm also going to talk about the 3P model of insomnia, and so just presenting some ideas in the current thinking about what is this insomnia, how does it happen, and what is the pathophysiology. I'm also going to talk briefly about the 5 components of CBTI, and then we'll just talk a little bit about what does CBTI look like in practice. So, as I said before, there are different types of insomnia. Psychophysiologic insomnia, or PPI, has some specific characteristics, and 4 of them I listed here. It doesn't always adhere to this specific criteria, but these are some of the more traditional kind of textbook types descriptions of insomnia. So it's characterized by a learned or learned sleep preventing associations. And people who have PPI will have typically an over-concern with their insomnia. They will describe a conditioned arousal. One very common thing people say is, I'm really, really sleepy, but the moment I get into bed, I feel wide awake. So they're conditions to insomnia or arousal in the bedroom environment. For that same reason, people will say they sleep better when they're not at home. So if they go to a hotel or another setting, they sleep better. They will also describe cognitive hypervigilance, so a racing mind, racing thoughts. My mind won't turn off. Feels very, I have conversations and worry about things at work at night at bedtime. The people with PPI also report decreased feelings of well-being during the day, and typically there's an inability to nap. So really I've never been a napper, I can't really take a nap. Those are sort of the typical characteristics of PPI. So the current model for insomnia is called the 3P model. This is called the Spielman model of insomnia. And it has 3 Ps. The first, or preclinical stage, is someone that has some predisposition to developing insomnia. So what is that? We think that these people have a hyperarousable nervous system, so type A personalities, people with anxiety, people with panic disorder. I've never been a deep sleeper. For whatever reason, just on that spectrum of arousability, these people have that genetic predisposition. So then there are precipitating factors in this blue period here when the insomnia starts, and the precipitating factor could be something like I was diagnosed with cancer, I got a divorce, I lost my job, something major in their lives that's stressful. And as we all probably know, when you're under stress, you don't sleep as well. And when you don't sleep as well, that can cause you distress, and it can cause you to change the way you sleep. And those people then develop coping mechanisms, so the green are perpetuating factors. And those perpetuating factors are what we think make the insomnia stay around for a long time. So many people recover from the stressful event, they go back to normal, whereas people with insomnia develop these maladaptive behaviors with their sleep pattern, and then have chronic insomnia over the long term. So why is this important? We target these perpetuating factors in CBTI, and that's the thought process around the treatment, is to target those perpetuating factors. So just going into a little bit more detail, I talked about this before. The predisposing factors are, weak central nervous drive, hyperarousability. These are some things that people try to measure with heart rate variability, body temperature, beta or gamma waves on brain waves, or just people who have emotional arousal or cognitive arousal. Again, the precipitating factor is usually a stressful life event. And then just to go into a little bit more detail with these perpetuating factors, because they are the focus of cognitive behavioral therapy for insomnia, they are sleep incompatible behaviors in bed. So Dr. Baumgaertel was just talking about using the smartphone at bedtime, using the smartphone in bed, that kind of thing. Hypnotic dependence, or using sleeping pills. Cognitive distortions, meaning people have certain thoughts about sleep that are dysfunctional. They're overly focused on sleep. And there's an unequal distribution of sleep across 7 days, or having an irregular wake time, or even an irregular bedtime. So this is a sleep log from a patient with insomnia demonstrating some of these concepts. And so the arrow down is when the person goes to bed, and then the arrow up is when the person gets out of bed. The blue line then is when the patient is, when the person is sleeping, and then this is actually when the person tries to go to bed. So that's kind of the sleep latency. And what you'll see here is what people with insomnia PPI do is they sort of cast a wide net, and it's like, well, I'm going to spend as much time in bed as possible because then I will be able to sleep the most. And that's a very common sleep diary from a person with insomnia. CBTI has 5 components: sleep hygiene and sleep education. Most of us have heard that term before about sleep hygiene, so we'll talk about what that is. Another thing called stimulus control therapy, sleep restriction therapy, relaxation and stress management, and then cognitive therapy. So we'll talk briefly about these 5 components. And again, our goal is to eliminate or reduce the perpetuating factors in hyperarousal. Generally, this is delivered in a group setting or an individual setting by a behavioral sleep therapist. And 6 to 8 sessions. It could be shorter than that. It really just depends a little bit on the person. So here are your typical sleep hygiene instructions. Don't drink caffeine after 4. Some people say noon, even earlier. Some people metabolize caffeine very slowly, and so that might even be too late. Nicotine is a stimulant and should also be avoided at bedtime and upon awakenings. Alcohol suppresses deep sleep. Even though it has a sedative effect, it tends to wake people up after it wears off. So that's another component. Avoid strenuous physical activity within 3 to 4 hours of bedtime. Physical activity raises the core body temperature, and our core body temperature actually lowers when we sleep, and so we think that this can have an effect on the circadian rhythm. Also, don't have a heavy meal, maybe a little bit, a light snack, but not too much fluids, not too much food before bedtime. Also, just use your common sense to make your sleep environment conducive to sleep. So, especially here in the Northwest, you want your room to be nice and dark in the evening, and probably even in the morning as well, because when it gets light out super early, that might disrupt the sleep pattern as well.
Those robins start chirping at 4.
Oh yeah, yeah, that's true. Sleep education is not a standard component of CBTI, but tends to be very helpful for people as a component to integrate, because when we're working on the cognitive dysfunction or the dysfunctional thoughts people have about sleep, if you actually teach people about sleep, what you're asking them to do makes more sense. And so I think it's easier to implement when people understand what the reason is. I typically give people information about normal sleep, changes in sleep with aging. I like to teach people about the basic sleep architecture and provide more information to help tie everything together. So sleep restriction is one of the most important components of CBTI, and actually, even on its own, has been validated as having a therapeutic effect for people with insomnia. So what are we doing when we restrict people's sleep? So we're increasing the homeostatic pressure for sleep. What that means is we're increasing the appetite for sleep. So we're making someone stay up longer, and the longer you're awake, the bigger appetite you have for sleep. So sleep debt is a term that a lot of people are familiar with, and that's what we're doing, is we're increasing the sleep debt. We're also preventing people from compensating for poor sleep by casting that wide net and getting into bed and being in bed 12 hours. And we're going to try to enhance also the regularity and the timing of sleep. So the treatment goal that I always pitch to people is we're really looking at quality. Let's stop being concerned about how many hours we're sleeping, and let's be concerned about the quality. One potential side effect of sleep restriction is daytime sleepiness. People can feel a little sleepier initially when they start implementing this component, and sometimes people will need to nap or lie down to rest when they're first starting this sleep restriction. I generally never go below 5.5 hours for people with sleep restriction, and it can be contraindicated for people who have mania or parasomnias. So here's an example of, again, someone with insomnia. This probably is a little out of order, but it illustrates sleep restriction. So here's someone with acute insomnia where they have early morning awakenings, and then they extend their time in bed, and they still, maybe the amount of sleep that they're getting is the same, but the way it's distributed, there's a big gap here. And then over the long term, it gets extended even more, and you see that perpetuation. So what we're trying to do with restriction is push in the bedtime, push in the wake time, and squeeze out that insomnia in the middle. So what I do is I give people sleep logs and I calculate how much time they're actually sleeping. Okay, so I can calculate what someone's estimated total sleep time is over a week and average that, and then I add 30 minutes, and that's the amount of time that that person should be in bed. There's probably 5 to 5.5 hours is what most people agree on, should be the minimum. We always establish the wake time first, and then the bedtime would then be determined by dialing back whatever the time in bed was supposed to be, because generally wake time is what dictates what people's schedule needs to be. I want people to maintain that for at least 7 days. If their sleep efficiency, which is a percentage of time that they're asleep that they're in bed, is greater than 85 to 90, then we can increase their time in bed. Alternatively, if it drops below, then we would actually restrict them more until we're able to get 90% of the time the person's in bed that they're sleeping. Stimulus control is another really important component of cognitive behavioral therapy, and it is also on its own a validated treatment for insomnia. This goes to the principle of conditioning, and the efforts to cope with insomnia lead to decreased conditioning of the bedroom and the bed in the bedroom with sleepiness, so that I'm sleepy and then I go to bed and I'm wide awake. So what we're trying to do is reestablish the bed in the bedroom as a stimulus for sleepiness and sleep to occur consistent with the sleep-wake schedule. So what does this look like? What I tell people is, if you find yourself awake in the middle of the night or at the beginning of the night and you know that you're not sleepy, you're wide awake, get back up out of bed, okay? If you're not sure, but you think it's been 15 or 20 minutes and nothing's happening, get out of bed, and we're trying to break that pattern. So that is something we will use in conjunction with the sleep hygiene, sleep education, and sleep restriction.
So you would have them go to a different room?
Yes.
Okay.
Mm-hmm. Yeah. Or at least, at the very least, get out of bed. And yeah, leaving the room would be ideal. Right. So the bedroom environment acts as a discriminative stimulus for sleep, and difficulty falling asleep results from that, being able to establish that particular stimulus. Okay, so we kind of went through that. So these are just kind of the general instructions. Don't go to bed until you're sleepy. If you're unable to fall asleep 15 to 20 minutes, get out of bed. Maintain a regularized time in the morning. Really, you want your wake time to be plus or minus 1 hour. Use your bedroom for sleep only. Don't, again, not on the smartphone in bed, not watching TV. Avoid naps. If you feel sleepy, you can take a short one, but keep it short. Otherwise, you're gonna start taking away your sleep debt, and it'll be hard to sleep at night. And I also talk to some people about a buffer zone, where they have like an hour to wind down in the evening. It's kind of a transitional zone, and it's a cue to the body that we're starting the process of winding down. And that's especially, I think, important for people who kind of go really busy all the time, and they need to their body needs to wind down. It's a process. Relaxation and stress management is also an important component of CBTI. Looking to address elevations in somatic and cognitive / emotional arousal, and those are incompatible with sleep. Sleep is a state of mind. It's a state about letting go and relaxing, and so with people, we're trying to reduce that cognitive and emotional hyperarousal. This is different for different people. It can be exercise for some people, it can be meditation, it can be progressive muscle relaxation, it can be writing in a journal, it can be reading, it can be a lot of different things. And I explore that with people about what is the best thing that they can do to address this. But again, this is going to address that, type A personality, kind of anxious. Again, these are just some of the examples: diaphragmatic breathing, progressive muscle relaxation, guided imagery, daytime stress management. One thing that a lot of psychologists use, I think, is something called scheduled worry time, where people have a set-aside time to make a worry list or write down things that are concerning with them, so that when they tend to have those racing thoughts at night, they can say, I have my scheduled worry time, I need to put that aside right now. This worrying is counterproductive and I'm going to do that tomorrow. The last component of CBTI is cognitive therapy. Again, addressing the dysfunctional beliefs and attitudes about sleep that develop as a reaction to poor sleep, leading to cognitive and emotional arousal and perpetuation of the insomnia. So when I was training at Stanford, one of the professors there used to give all the patients a Chinese finger trap. I don't know if you know what that is, where you put your fingers in, and if you try really hard to pull out, that it makes the problem worse. And so as Americans, or maybe not just as Americans, but as humans, we all have such a strong feeling that if we try harder and if we work harder, that we're going to get better results. And sleep is really, the antithesis of that, that it comes by letting go, it comes by not trying. And I always remind my patients, which probably annoys them, that people who sleep really well don't think about it, and they don't worry about sleep. So we talk a lot about reducing this reactivity to not sleeping. I see this reactivity a lot as well with hypnotic use, that people, it's kind of a knee-jerk reaction, well, I'm not sleeping, I'm going to take that pill. And so helping people learn how to, follow a different thought process and a different pattern of behaviors for when they can't sleep. And I think some people really have kind of a mystical thinking about sleep, that while I took this and I did that this day and this is what happened, and really it's much less magical than that when it comes to sleeping well. So another way that we address these maladaptive cognitions are by using sleep logs, because people often have a very faulty appraisal of how much difficulty they have sleeping, meaning that if you ask people to estimate how much difficulty they have sleeping, it's really out of proportion to what's actually happening. And if you can get people to log it and they can actually see, then it's sort of reassuring for people to see it's not as bad as they think. And then also, we talked about casting a wide net, cognitive errors, so rumination, catastrophizing, overgeneralization. So if I don't sleep tonight, I'm gonna, be late to work, and if I'm late to work, then I'm not gonna complete this project, and then I'm gonna lose my job, and if I lose my job, then I'm gonna get divorced, and it just goes into the snowball of, catastrophizing. And so we try to help people work through that process and see that it's not constructive. Again, so exploring, clarifying, and challenging the validity of those cognitions, and providing more adaptive and rational substitutes. So we might make a hypothesis to be tested by the person, have them test it for the next time they see me, and see that they're not absolute truths, and encourage more flexible thinking about sleep. So here's an example. Person finds themselves awake in the bed in the middle of the night. They think, oh, I can't sleep now, therefore I will not be able to function tomorrow. Are you sure? Have there been times when you didn't sleep well and you're still able to function? And the person thinks about it, well, gosh, this has been going on for 10 years and I'm still functioning. So an alternative thought would be, there's no point in dwelling on this now. Sometimes I can still function after a poor night of sleep. So just to summarize, these are the 4 or 5 components plus the sleep education of CBTI. Sleep hygiene is, the goal is to eliminate habits that are counterproductive for sleep. With stimulus control, we're trying to strengthen the bed and bedroom as a sleep stimulus. With sleep restriction, we're restricting time in bed to improve sleep drive and consolidate sleep. And with relaxation training, we're reducing arousal, decreasing anxiety. With cognitive therapy, we address thoughts and beliefs that interfere with sleep and daytime functioning. And then with sleep education, we're providing a rationale for all of these other components. There is very good empirical support for CBTI. This is the state-of-the-art treatment for insomnia, or PPI type of insomnia. There are several studies. I just have one cited here that shows that 70 to 80% of people who have CBTI experience a benefit. They have a reduction in their sleep latency, so the time that they get in bed till the time they fall asleep. And WASO is the wake after sleep onset, so this is how much you're awake in the middle of the night. Those are reduced by 50%, that's one of the outcome measures, and increased total sleep time from 6 to 6.5 hours. The other benefit of CBTI compared to medications is that CBTI persists beyond the treatment termination. And so the onset of relief is a little bit more delayed than medication. Medication's a little quicker to act, but it doesn't last as long, whereas CBTI has a little longer lasting effect. So just in practice, what does CBTI look like? I have usually an initial consultation with people for 30 minutes. Sometimes it's a little longer, gathering to see if the person does have PPI, if they're a good candidate. People do need to be able to provide a history and complete sleep diaries, as well as be willing to cooperate and be compliant to outline concrete goals. Some people won't even complete sleep logs, so that makes it really hard, as you can tell, for me to implement these measures. We usually start with the sleep restriction, stimulus control, sleep hygiene, and then add in the cognitive therapy and relaxation as we need to. I generally kind of calibrate this based on my experience in talking to the person and saying which of these components will be most useful in this particular case. Not all of the components are always necessary, and we use the synthesis of these components. 6 to 8 weeks, 2 or 4 sessions have been documented in the literature to be adequate for a change. So it doesn't take that long, especially if most people have had insomnia for a long time when they come in. So again, just appropriate people. You need to be able to keep the logs. You need to be able to come in for regular visits. You've got to be cooperative, and it's great if you're focused on a non-pharmacological intervention, so you're not looking for a pill, or maybe you're looking to get off of your pill. Willingness to make changes, receptive to the treatment rationale, and willing to address comorbid psychiatric problems. So if anxiety or depression are, what I see or your primary care doctor thinks are a part of the insomnia, then we need to address that as well. There aren't really very many risks associated with CBTI, but if there is a history of bipolar disorder, mania, or untreated sleep disorders can be exacerbated. A little bit of daytime sleepiness, especially initially. If it's not done well, people could discount it or maybe not be receptive to it in the future. You can use CBTI with meds or to get people off of meds. I think the group is really great. They have a group, they have groups at other places, but we haven't started that yet just because of size. Can people use CPAP for sleep apnea if they're going through CBTI? Absolutely, they can. And if sleep apnea is really the main problem, we want to focus on the CPAP. But if you're stable on your CPAP and you're still having insomnia, then certainly CBTI can be an appropriate treatment for you. So that's the end, and I'll be happy to answer any questions or any further comments.
Question.
Yeah.
So does the length of time someone's had insomnia, like for years and years and years, is that a factor in whether or not they'll be successful in this method and improving it? Some of my patients have had insomnia for 30 years, and does that mean they're going to have a harder time or be less successful?
No, I don't think so. I think it can be, they might require longer treatment, that they require more sessions, just because the pattern is so ingrained, but those people can respond really well. Yeah. It's really interesting, because insomnia is so complex, when you really get to the bottom of it for different people, it can be very nuanced. I had one lady that I remember I saw and I worked with, and the thing that really ultimately, and this kind of goes against what I told you, but we did do all these components, but the thing that really solved her insomnia was she had this wood paneling in her bedroom, and it was very dark, and she had this really intense resentment of her husband about this wood paneling because he loved it. And so what she ended up doing was she said, you know, I just don't need to sleep in the same room as my husband anymore. And she moved to a different bedroom. She painted it light colors. And it was like she was emancipated from her insomnia. But it took us a while to figure out how much that would help. Yeah. So it can be very nuanced for people to find out what is at the root of it.
What about the ambient temperature of the bedroom? So before the talk, Harry and I were talking about, you know, back east and it's cold winters and so forth, and a lot of people turn the thermostat down. Is a cold room better, or does that affect its ability to sleep soundly?
Yeah, I think, you know, the body does lower, the core body temperature lowers during sleep, and so you don't want it to be cold, but cooler is better generally. And in order to achieve a lower core body temperature, we have a lot of vasodilation, so a lot of people, you know, will be aware of that. You know, maybe you're itchier or sweatier, I don't, you know, but yeah, certainly having it cooler is generally better. You don't want it to be cold, you know, you want to be comfortable, but generally lower temperature is more conducive to sleep.
Couldn't do that. But I did have a question. Would this help a person? I don't have a problem going to sleep. I can go to sleep within a second, but it's staying asleep.
Traditionally, PPI is more of a sleep initiation problem, but certainly staying asleep is something that we would target with CBTI as well. It would be something where, you know, to answer the question for you, you know, you would want to have a consultation to see if there's something else causing that, because many things can cause, you know, trouble staying asleep.
I hope you all had a lovely sleep tonight.
I know, right?
All right, great.